Good evening, everyone. Thank you for joining us for the lectureship this evening, which is supported by a generous gift from the Berkowitz Family Foundation. I had the honor of meeting Mr. Berkowitz several years ago when he first gave the gift and participated in the first couple of lectures that we had. We're joined here tonight by his wife, Barbara. Barbara, if you give a wave, and his children, Arthur and Penina. So it's great that we could all be here live and in person participating in this. Mr. Berkowitz was an excellent businessman and a passionate community leader. In fact, his company installed all the glass in our beautiful medical education building here. He passed away in 2016 from cancer. He was born in Philadelphia, served in the Navy, was a graduate of the University of Pennsylvania, an economics major. And he married Barbara. They were married for 65 years. In addition to Arthur and Penina, they have two other children, Alan and Dan. He was chairman of the board of his company's business that was founded by his father in 1920. And not only did the company provide the glass here locally, but really it's a national company that has done glass for many noteworthy developmental projects. But above all else, beyond his work in his company, he was committed to community. And he was a driving force for other philanthropic endeavors within our region. It was at a very personal level, as he battled cancer, that his interest in medical ethics and the importance of humanism were born of that personal experience. And he funded the lectureship not only here at Cooper/CMSRU, but also a similar event at Jefferson in Philadelphia. So it's with great gratitude that we acknowledge and honor Mr. Berkowitz and also acknowledge his family as well. So let's give a round of applause to them. And this year, we have the pleasure of also welcoming our speaker, who is one of our emergency medicine faculty members. He's here tonight with his wife, Anna, who's a faculty member in ethics at the University of Pennsylvania. Dr. Jonathan Reisman. We're looking forward to his presentation, and he wrote a book. It seems to be a popular thing, Dr. Mazzarelli, among the emergency medicine group now to write books. This is another book within the realm, you know, Dr. Mazzarelli, Dr. Treziak's book, Compassionomics, and then their second book as well, Wonder Drug. So I think we're starting a little trend here with that. I'd now like to turn the program over to my dear friend and colleague, Dr. Anthony Mazzarelli, who's president and co-CEO, co-president of Cooper University Healthcare. He'll be introducing Dr. Reisman. Thank you.
Thank you. Thank you, Dean Raboli. That is a challenge because Dr. Sunny Patel is here, so he's got to be next to write a book. That's an official challenge, I think. So welcome, everyone. We're happy to host this event with the medical school. Thrilled to have members of the Berkowitz family here with us tonight. I always look forward to this event. As the dean said, humanism and compassion and medicine, something I truly feel passionate about. And although the worst of COVID is behind us, we in the healthcare community are still processing a lot of the lessons that the pandemic taught us, not just about our profession and the patients we treat, but ourselves. Modern medicine is on the cusp of an era of powerful therapies, novel drugs, gene and targeted therapies, artificial intelligence, digital technologies that have the potential to transform our field. However, the pandemic and much of the narrative about science, research, and vaccines became a hot-button sort of debate topic, and us as physicians were stuck in the middle. So our speaker tonight will delve into some of these questions by drawing insights from his very unique career, practicing medicine all over this country and really all over the world. So tonight we're going to hear from Dr. Jonathan Reisman. He is, as the dean mentioned, in the Division of Pediatric Emergency Medicine. He's an assistant professor of emergency medicine here at CMSRU. Dr. Reisman graduated from New York University with a BA in mathematics and received his medical degree from Robert Wood Johnson Medical School. He trained in a combined internal medicine and pediatrics at Massachusetts General Hospital. And since finishing his residency, he has mostly worked in rural and remote emergency rooms throughout the country, including in Arctic Alaska, Pine Ridge Reservation in South Dakota, and several hospitals in rural Pennsylvania. He's practiced wilderness medicine in remote parts of the world, including Antarctica, the Russian Arctic, and at high altitude in Nepal. He's conducted public health and global health research in Alaska, India, Tanzania, Kolkata, India. He began writing as a medical student, and his essays have appeared in the New York Times, the Washington Post, Slate, Discover Magazine, and his first book, as the dean mentioned, The Unseen Body, which all students have received a copy, was published last November, is being translated into 6 languages. So before we bring up Dr. Reisman, I also want to thank the Berkowitz Family Foundation, obviously to honor Mr. Edwin Berkowitz, whose experience as a patient gave him the vision and foresight to invest in medical ethics education for this next generation. Really now, if you think about it, several generations of professionals. So I think we did it once, but we should do it again. We want to please join me in thanking the Berkowitz family for making this possible. So thank you. But with that, I want to welcome up Dr. Jonathan Reisman.
Hello there, everyone. Thank you so much for having me today. It's really a great honor to be here. I was a medical student here as well many years ago, before it was its own 4-year medical school, when it was Robert Wood Johnson. And it's really amazing to think back on every patient, if I could count how many patients I've seen and evaluated and diagnosed and treated since that time. 10,000 maybe? Lots of thousands. So it's pretty amazing to think how much you see and do and learn from each patient that you see as a doctor. All of it hopefully making you more of a humanist, more of a humanistic practitioner of medicine, more ethical, hopefully, but certainly, if nothing else, teaching you. You know, we always talk about being a lifelong learner as a doctor, and it's really true. I mean, you absolutely never stop learning, especially, I personally love working in the ER. You really never know what's going to walk in that door next, and I never stop being surprised at the things that I see, the problems that the human body can present with, or even just society or the social relations of an individual person, what kind of stresses they can put on the body and the mind. You just never stop being fascinated and interested in the body and in people in general. And I think that's really an important ingredient in being a humanist or practicing humanistic and ethical medicine. Being fascinated with the human body and being fascinated with people, the lives they lead, the successes, but also the failures, the pains, the discomforts, the problems of the human body and of human society in general. We really get like a front seat at what the human body, all the good and bad things that it does and that happen to it. And so it's really wonderful to be a doctor. I just want to start by again saying I really love being a doctor, and I think that having compassion, being a humanistic practitioner of medicine, is really important, both for the patient but also for us. Right? Burnout is super common among doctors. You know, historically, doctors have a high suicide rate among professions. There's a reason. It's a very stressful job. You have a lot of responsibility when people entrust their bodies, their problems into your hands. And I think maintaining our fascination with the human body in all of its flavors and varieties and is as important for delivering good care to that patient as it is for us enjoying our jobs, continuing to enjoy our jobs for decades and decades, and not and avoiding the problems that can arise. So a lot of times it's the two sides of the same coin. Maintaining your interest, your fascination, your humanism is important both for your patients and for yourself. So so it's very important, and that's kind of the theme of the talk. But I do really love being a doctor. I've been practicing for about a decade. It's not burnt out yet. Hopefully it stays that way. And I think that part of that is the fascination with the human body. As I mentioned, when I started medical school here in 2006, I believe it was. From the first day when you put your scalpel on your cadaver's skin and start opening it up and seeing what's inside of it, I was really taken and fascinated by every little detail. I wanted to know the name of every little structure in the body. I mean, I sort of had to know all those names for the tests, but I really wanted to know everything I could about the human body, the name of every disease and every eponym and everything about the human body. I was really fascinated with it. And I always liked that when you're looking into another human body, when you're looking into that cadaver's abdomen or chest or looking at diagrams of what is inside the human body, you're really learning about what's inside your own body at the same time. So it's almost this philosophical exercise where you're cutting open this other person who died. You don't know anything about them, their name, what their life was like, only what you can glean from looking at their internal organs. And by learning about them, you're learning about every person that you'll ever see or meet or know, or every patient you'll ever treat or evaluate, and also what's going on inside your own body. And I always kind of love that. And we as doctors, we're so lucky. We get a front seat at this human body, and we get to know it on so many different levels, right? We know it on the molecular level. From there, you can zoom out to the cellular level. We know it on the tissue level, the organ level, on the organism level, the whole person. You can zoom out even further to population level and epidemiology and biostatistics. And so you get to know it intimately on all those levels, and it can be really a privilege. But one of the most most privileged aspect of being a doctor is that you get to know it on the human level, because we are humans and we relate to our patients as one human to another. And it's such a special thing we get to do, right? You go into your exam room, and these complete strangers come in, or if you work in the ER, let's say, complete strangers you never met before in your entire life walk in, and then minutes after you introduce yourself, you're talking to them about their most intimate, private aspects of their life, their secrets, what's going on in the bedroom, what's going on in the bathroom, about the blood in their stool, that they might, even though they just met you, tell you things that they won't even tell their spouse, who they share a bed with every night for the last 30 years. So we're kind of given this amazing privilege, this amazing view of humanity, not only of the human body and its kind of mechanistic workings, but also the lives of people, what scares them, bothers them, hurts them in their daily life, and it's our job to figure out why and fix it, hopefully. Not always, you can't do it every time, but it's really great. So I really think it's such a privilege to be a doctor, because we get that front seat view on humanity itself. And I think that is why, as was mentioned, doctors often tend to write, because I think we get to see so many amazing things about not only the scientific mechanistic aspects of the body, but just humanity, how people live their lives, how they relate to other people, how they relate to what's going on inside their own body, which is often a mystery to them, which we try to kind of help solve. And I think loving humanity and being endlessly fascinated with our bodies, kind of in a mechanical way, but also in an emotional, spiritual, every other way that you can know another person. That's very important for being a humanist. So I encourage you to continue that. Now, Maz mentioned some of these things. You know, we're on the verge of this golden age, this perfect medical era where we're going to be able to diagnose and treat all these conditions that we've never been able to before. You know, the lion's going to lay down with the lamb. It's going to be paradise and utopia, and we're all going to be perfect at diagnosing and treating every condition. There's so many promising things going on now, right, with CRISPR. Maybe we're going to be able to edit genes like we never have before and cure some of the inborn errors of metabolism and conditions like sickle cell, which are the result of a genetic problem, basically. Or the mRNA technology, which has grown recently, promises new and better vaccines or even new and better treatments. They're doing studies on conditions like PKU, actually, like a weekly IM injection of mRNA to supplement the enzyme that's sort of missing because of the genetic defect. So mRNA has potential beyond just vaccines. You know, I feel like you hear so much in the news about all these promising technologies and all these optimistic, you can see people giving lectures on all these topics that promise so much to come. You know, 3D printing, people are going to print their own pills at home, and we're going to be able to print organs for transplant with the recipient's own cells, so there'll be no more fear of rejection, because we'll take a collagen matrix with no cells and just print the person's cells onto it, and it'll be like their own organ. Maybe, hopefully, one day, perhaps. or big data and AI are going to help us see all these different connections between treatments and diseases and root out new side effects that we never noticed before, and optimize medicine, and understanding genomics is going to give us precision medicine and personalized medicine. It's almost a little exhausting sometimes thinking about all the promising new technologies that are coming. And I think for all you medical students and residents out there, you're going to be practicing during this, hopefully, new and better era of medicine. But, as Maz also said, there's a lot about the coming era in medicine that presents a lot of hazards and a lot of pitfalls for the practice of medicine. So COVID was really a big stress on the healthcare system, obviously. I'm not going to talk too much about it, but basically the pandemic really kicked American healthcare in the teeth, and I think we're still kind of crawling out of that, and it had a big impact on a lot of nurses, doctors, and other providers and workers. And I think, you know, that initial era where doctors were the heroes and getting clapped for, I feel like that's long over. Nobody's clapping for us anymore. Everyone has their own struggles, and so we have to kind of get past as much as we can everything that happened during the pandemic to try to kind of get back on our feet. But I think COVID really accelerated a lot of trends that were already in motion. I think a lot of people were becoming a little losing their faith in some of the larger agencies, the medical institutions that have sort of set medical policy and provided guidelines and recommendations for everything that we do. I think that faith was probably already in decline, and COVID really accelerated it to a pretty impressive extent. And I think faith in expertise of all sorts these days is basically in free fall in the American public. And so that is going to have a big impact, I think, on everyone's future career here. The way you interact with patients, the way people see the advice that you give, the way people receive the recommendations that you do recommend. And there's going to be a lot of fallout of that loss of faith and expertise. Probably going to be less vaccinations among kids. Things like measles, polio, probably going to make a comeback. I haven't had to deal with those diseases so far in my career. I didn't have to deal with them as a kid either. I never got them. But all that can change pretty quickly. Also, what's interesting, I think, is that during COVID especially, there was almost this democratization of medical information. You almost saw in real time how medicine was building its own evidence base for the treatments and diagnostics related to COVID, and the public was also following along and learning all these terms of relative risk and all these terms that honestly I struggled quite a bit to understand when I was in medical school. I always found epidemiology and biostats to be the hardest course of all of them when I was a medical student here, and still struggle with it a bit. But I do think that, you know, the public is much more savvy about what the evidence base looks like in medicine, and what treatments and what diagnostics really have a good evidence base. And if they weren't aware before, they're more aware than ever that a lot of the things we do have a garbage evidence base or none at all. And I think that's something that also the coming decades we're going to have to deal with quite a bit. They're on to us. You know, we often say that when you finish medical school, 50% of what you learned is wrong already. Right? I mean, to some extent that's true. Medical science changes so quickly, and thank goodness, because we're learning more, learning that things we used to do were wrong, or not helpful, or actively harmful for patients. So it's certainly good to progress and to learn more and to do things better and more efficiently. There's no one who doesn't want that. But that comes with knowing that a lot of what you tell patients and recommend is wrong. Like the treatments you're giving, some of them are wrong. The evidence base behind them, much of what I learned to do in medical school and in residency probably is wrong, probably is more harmful. So the evidence, we have to kind of be ruthless about sticking to our evidence base. That's going to be really important in the years to come. And, you know, there's studies like this recent one that came out about colonoscopy, screening colonoscopy to reduce colon cancer deaths in Europe, that kind of question the practice. I mean, it's very far from definitive, but those kind of studies are in the public awareness now. And so I think the things that we do and recommend and say to our patients are going to be questioned more than they ever were before. And to some extent, that's good. They should be questioned. We should be questioning ourselves as well, again, because the evidence base doesn't always support what we do. A small example, when my wife was pregnant, actually, we found that going on these pregnancy forums on the internet was so much more helpful than talking to her OB, who was a fantastic OB, don't get me wrong, she was brilliant. But like you go online, you ask a question, and you can hear answers from 50,000 different women who are going through the exact same thing that you are at that moment, just as far along in their pregnancy as you are. In some ways, that is much more useful. than what the doctor, maybe a young doctor who just got out of fellowship and actually hasn't even seen that many patients. Or even a doctor who's been practicing 30 years. You're talking about one person's experience versus tens of thousands of people. This is just kind of more of the democratization of medical information, where people are going to get their information from. We're not the sole owners of medical knowledge, not even close. I mean, the internet is so full of great information, and people are going to be, whatever knowledge you have in your head and are going to be imparting to your patients, there's going to be a lot of competition. So it's important to adjust to that. We're still dealing with things like the opioid epidemic. Your generation, for you students and residents out there, are going to have to be the ones to kind of find a better balance with these medications that can be dangerous. Every medication comes with its little insert that warns you about its side effects. I don't think the opioid inserts mention that you could become addicted and ruin your entire life and your entire family's life. That's probably not there on the insert, but we know that that is true. And while I think we've gotten much better at being more judicious with our opioid prescriptions, our society, American society, is still dealing with the fallout of that, which we did help. Not every single one of us, but a lot of doctors kind of helped promote that and helped start that fire. And you can see there's not much signs that that is getting better. And while I think more overdoses these days come from illicit drugs bought on the street than ones prescribed by their doctors, still there's tons of improvement. Even better, actually, would be to invent a new kind of painkiller that's just as good as opioids but doesn't have the addictive side effects or the constipation side effects. That would be wonderful. That's like a frontier of medicine. If you can invent that, you'll really transform medicine. That would be great. You're also going to be practicing in kind of a weird era where marijuana is legal or about to be legal almost everywhere, where psychedelics are about to become prescription medications, I think. It seems like, ecstasy, MDMA for PTSD, and psilocybin, magic mushrooms for, I'm not even sure what, depression and end-of-life ennui. But that's going to be interesting too, and I think the off-label market for those drugs is going to be really interesting. Psychedelic spas and come free your mind and treat your depression at our, I don't even know what kind of infusion center. It's going to be very interesting, and just a kind of a different way or different context in which you're going to practice. But I think that there is kind of broad understanding that in many ways the healthcare system is not working these days, both for patients and for practitioners too. And as I said, those are kind of two sides of the same coin. And I think something that we're all going to have to deal with in the coming years. One other interesting thing, did you know that patients can actually order their own labs online these days? It's true. So my wife, a few years ago, had a rash on her leg that to me looked like petechiae. So it looked like a rash that's associated with having low platelets. And so I wanted her to get a CBC, a cell count check. So I recommended she call her doctor. And the doctor said, I have room in my schedule next Thursday, which was like 4 or 5 days later. I was like, no, we're not waiting for that. So actually, since my wife is in bioethics and studies this kind of thing, we found she could actually go online, order her own CBC, and then just go to Quest, not like some fake lab. It's a totally real lab, the same lab you'd go to if your doctor prescribed that lab test. Went to the lab down the street, got the CBC. We had the results later that day. Her platelets were normal. Fine. It wasn't petechiae. I was totally wrong. I was thrilled to be wrong. But that's another aspect of what's coming. So, and you go to these websites, there's a whole menu. You can order almost any lab you want. So that's another thing, another interesting aspect of medicine to come, I think, that's in the future. So I think if there's one theme to my talk today, it's that in many ways we must get out of our bubble. You must get out of your bubble to be a better doctor, to be a better humanist, to provide better care to your patients, and also to provide, the optimal care and the optimal lifestyle for yourself. You must get out of your bubble. Doctors have to get out of their bubbles, understand the patient's viewpoint. You have to understand what the barriers that patients face when they're trying to access medical care. If you're ever a patient yourself, you learn very quickly about all those barriers and how frustrating it can be, like trying to get a blood test from your doctor and they're telling you to come next week. And your paranoid physician husband is worried that you might have leukemia or something, and they don't want to wait 4 days. But bless you. So this is the problem. What does it mean to get out of your bubble? I feel like everyone's often talking about bubbles these days, right? We're all in our own media bubble, and our own political bubble, and our socioeconomic bubble, and our society's fractured, and we're all in our little worlds, self-contained, never leaving them to see what's on the outside or how other people see things. And that's true in society, but it's also true in medicine. You know, if you work in a large academic center in the city, there's a lot that you don't get about what it's like to work in a very small rural or remote hospital in the US. A lot of concerns you have to take into consideration and the time it takes to transport patients from one place to another. There's so many things. So I worked in a lot of rural and remote parts of the US, and the things you learn there are just, it's almost like a different world. I mean, you literally are practicing medicine in a different world with so many different questions and concerns and things you have to take into account. It's more challenging, but it's more needed, of course. And healthcare, in those places where those challenges are, there's often a greater need as well. So I'm going to talk a little bit about my career, all its twists and turns and all the interesting places I worked, partly as just a demonstration of how sort of I got out of my own bubble and learned a lot of things by working in different places. Also, just if you're a student or resident, I hope you're inspired to go have fun medical adventures in similar places, because your medical degree and your training is really a ticket to lots of fun and exciting adventure. And again, in those places where there is often excitement, there's often a greater need for medical care too. They're often underserved. So you kind of accomplish both things at once. So as I said, I started here, during just the clinical years of medicine. My third and fourth year of medical school were here in Camden. I took a year off between my third and fourth year of medical school here. I actually got some great advice from a student who was in the class just above mine. He had taken a year off to go do global health, and he said to me, the next time you're going to be able to take an entire year off from your career will be when you're retired. And I was looking into the future and thinking that's at least 40, 50 years from now, so maybe I should do that now. So I did take a year off from medical school. I was very privileged to have the opportunity to do that and to be able to draw my loan for medical school that year off year also to pay for my adventures. But what I ended up doing was I spent about 6 months in India, and that was very enlightening. And the first 2 months were in the city of Mumbai. And traveling to India, as someone from the US, someone who grew up in the suburbs of northern New Jersey, India was eye-opening in about 10,000 different ways. From the culture, the food, the religion, the sights and smells and tastes. You kind of get out of your bubble in about 1 million different ways just by walking around an Indian city. And so, in a way, I got out of my medical bubble, too. So I volunteered or did an observership at KEM Hospital in Mumbai, which is a public hospital, so it focused on providing care to poorer people from the lower castes and lower classes who can't afford care in a private medical hospital. And it's there in urban Mumbai. And I often say that observing at KEM Hospital, rounding with the internal medicine team, was kind of like seeing your pathology textbook come to life, because I saw patients suffering from so many diseases that I had learned about in medical school, but would probably never see, probably not even once. Although with less vaccinations, you never know what's going to make a comeback. But other than that, you probably could work an entire career in the US practicing medicine and never see some of the diseases that were just everywhere in KEM, like TB, tuberculosis, and all of its manifestations from pulmonary to the lymph nodes to the upper gynecologic tract to the intestines. Kind of TB goes everywhere, does everything, shows up in 1 million different flavors, and I think I saw all of them maybe there at KEM. You see rheumatic heart disease and leprosy and the after effects of polio and malaria and dengue and leptospirosis and all these other, not only tropical diseases that you probably wouldn't see in the US because we're not in a tropical area with malaria-carrying mosquitoes, but also just diseases you don't see here anymore because of better medical care, like rheumatic heart disease and completely untreated congenital heart disease as well. And I think KEM was also really interesting because a lot of the patients who were coming in were coming in with end-stage forms of their disease, because a lot of these people are poor, their families depend on their day-to-day paychecks. They really cannot take a day off from work to go seek medical care until they literally are too sick to even get up to go to work. And so a lot of these people were coming in when they were literally too sick to even get up and go to work, and so they were often very end stage. And their physical findings were often very prominent. And their rheumatic heart diseases, murmurs that were so loud, even I could hear them, where, coming from a place where we kind of get an echo at the drop of a hat when we want to characterize valvular disease. Or I remember one very skinny man who was basically dying of anemia from thalassemia, His liver and spleen were so big that you could see them both kind of moving up and down in his abdomen as he was breathing. He was also very skinny, wasting away from his disease. And so this kind of got me out of my bubble, obviously, to a place where care is much harder to access and where people don't have access to even some of the most basic and simple forms of care. While I was in India, I learned about the incredibly high number of children, for instance, that die from diarrhea in India and elsewhere in the developing world. You know, when I was a pediatrics resident in Boston, you get a kid with gastroenteritis, they have diarrhea, maybe some vomiting, they're dehydrated. You'd give them some IV fluids, admit them to the hospital for a day or two. It's the most ho-hum admission you do as a resident. It's not very intellectually satisfying or interesting. It's super easy, it requires almost no thought. Yet in India, every year, hundreds of thousands of children, a staggering number, die because they do not have IV fluids. They don't even have access to really good oral rehydration solutions, which could probably save quite a bit of them. They're dying of dehydration just from diarrhea, which is something that thankfully very rarely happens here in the US. One other case that helped kind of demonstrate the difficulties with access to healthcare, I actually saw a patient in KEM also who was dying of rabies encephalitis. So once you get the encephalitis, it's almost 100% fatal, or actually 100% fatal, except for maybe one or two questionable cases. But this man, he lived in rural Maharashtra, the state in which Mumbai is, and he was bitten by a dog. There's a lot of feral dogs in his area. Went to the local health clinic to get the post-exposure prophylaxis, the shots you get after a bite, which prevent you from rabies from getting into your brain and causing that fatal encephalitis. And they were out of it. So he could have traveled on to Mumbai, which would have taken him hours and hours on the bus and train, but he couldn't because he had to go back to work. So he went back to work, and then months later he came down with the encephalitis, and his chances of dying were 100%. And he did die there in the hospital. And so that was, again, it's the same sort of extreme lack of access to medical care. And I think there's certainly similar things go on in the US, not to that extreme, but certainly getting out of your bubble, seeing how things are elsewhere, can also tell you about or give you perspective on what's happening inside, your own bubble, or here in American healthcare, where we're a bit more privileged than that. So getting out of your bubble is not just to see what's in the other bubble, it's to get perspective back on your own bubble, your own life, your own practice of medicine, your own healthcare system, your own privilege, all that good stuff that helps you be a better doctor and a better humanist. So after Mumbai, I went to Calcutta on the other side of India, and I worked for a charity there called Calcutta Rescue for 3 months and helped provide medical care to people who live on the streets and in the slums of Calcutta. And one thing that really impressed me about Calcutta was how many things are happening out on the street, things that would happen behind closed doors here in the US. So here on the city street, you see goats and sheep that are being brought to slaughter in a huge herd. This was actually a frequent sight in the area where I was staying in Calcutta. Everything happens on the street. There on the left, you could see it's basically like a metal fabrication factory, and they're just doing it out on the street, welding what you'd normally expect to happen in a factory. Or in the middle picture, this guy's an accountant, just helping people with their taxes right there on the sidewalk. Or on the right, you can get a haircut and a shave in Calcutta right on the street. It was actually great. The only straight razor shave I've had in my life. Very luxurious. People pray on the street. You could see a shrine there on the tree. Pictures of Shiva, and that black thing with the face is the Shiva lingam. And to the right, it's another kind of little, you see these all over Calcutta, just a little shrine to one or another god or goddess. This was right outside of a slum where we were doing some medical care for people. Everything happens on the street in Calcutta, and medicine also happens right on the street. So Calcutta was kind of introduction for me into what we call street medicine, or medicine, without walls, basically. You're there on the streets, in the slums, trying to deliver health care in a very different context from what we're used to in these kind of high-tech bubbles full of technology in a modern hospital. So I worked with the street medicine program. You could see that's our van on the right. There was a doctor there who worked for Calcutta Rescue who I assisted. And then on the left, you could see that's one example of a kind of a sidewalk. I don't know if you call it a village, but people just live here, sleep under those blankets at night. Those were the kinds of patients that we were treating in street medicine, people who live on the streets and in the slums. And it's really, Calcutta Rescue really does amazing work and provides impressively high quality medical care and very evidence-based medical care as well to some of the poorest people on earth. And it's a very difficult population to treat. You know, they're often moving from one part of the city to another. In the summer, the monsoons come and flood parts of the city, and you have to completely take down and move and rebuild everything, the slum, that house that you live in, or in these cases, maybe just a blanket. But also sometimes these people are migrant workers and go back and forth from the city to back to their village, and so following up on treatments, making sure they're getting the diagnostics you ordered, or their second dose of whatever is needed. Some children get vitamin A supplementation every 6 months, and so sometimes that second one, it can be hard to find the people. Sometimes the police kind of bust down an illegal slum, or sometimes they catch fire and everyone has to go find a new home. So delivering care to this population is very difficult. Another thing that was eye-opening for me, one of the projects I worked on while I was there was figuring out why some of Calcutta Rescue's school kids, so they actually run 2 schools as well, in addition to providing health care, why were some of the kids still getting malaria from certain parts of town? So they handed out bed nets to all their students. And in certain parts of town, the kids were still getting malaria. And in the other parts of town, it seemed like it was much fewer cases, or perhaps none at all. So that was one of my projects. They sent me out to those parts of town to visit some of these students in their homes, along with a translator and one of Calcutta Rescue's health workers, to figure out why isn't it working, right? It's a 4-cornered net, simple as could be. You tie each corner, there's a tie on each corner, you tie it to a wall, nail it to a wall, whatever it is, a bamboo stick, you can just tie it to anything. And when I got there, of course, I found that the reason that they were getting malaria was because they couldn't use the bed nets. And why couldn't they use the bed nets? They had no walls to tie it to, obviously. So people who were living on the street, you could see where you're going to tie that net to on that sidewalk right there. So these were parts of the city where people weren't even living in slum hovels. They were living on the sidewalk itself. And so, those barriers, like why isn't the treatment working? Like doctors kind of have to, sometimes the treatment doesn't work. Is it because you got the diagnosis wrong? Is it because you gave the wrong dose? Or is it something that you have to figure out by kind of going and seeing for yourself, like what is going on in this patient's life? What is going on in their home? That's another way of getting out of your bubble. It's not just a matter of what you did, the order you put in, sending it electronically to the pharmacy for that needed medication. Why isn't that medication getting into the patient? Or if it is, why isn't it working? Sometimes the answers to that, it's really hard to answer unless you go see for yourself, investigate for yourself. So, right, the word autopsy, right, means seeing for yourself. Modern medicine, all of our medical knowledge basically is based on autopsies, or at least that was the origin of kind of modern medicine, the modern understanding of disease, right? In the mid-1800s, doctors started cutting open dead people and being like, oh, they're not dying from imbalances of the humors, they're dying from these things I can point to, like tumors and aneurysms and abscesses and infections and blood clots. So seeing for yourself, that's another kind of autopsy. You must see for yourself and get out of your bubble. I even got a new perspective on feces while I was in India. So here in the US, right, it's something to be it's the most odious of waste products from the human body, to be flushed away and discarded and never thought about, or certainly never talked about in polite company. So in India, on the left there, you could see a wall with a bunch of poop patties, for lack of a better term, and you could see a handprint inside of each of them. So I saw someone there just kind of with a big bucket of it, and just sort of plopping up all these little things on the wall for them to dry. This is the primary source of fuel for cooking fires for people who do live on the streets and in the slums of Calcutta. So poop can be very useful, in fact necessary, not just a waste product. So that was a different perspective. And of course we figured that out in Western medicine too, right? On the right, those are fecal microbiota transplant capsules, or stool transplants. So inside of each of those capsules is human stool, which has become, to some extent, a standard of care for people with refractory C. diff colitis. So another way that poop can be useful, and that you can change your perspective. In fact, I feel like FMT is maybe symbolic of what's to come in the 21st century with medical care. I feel like the 20th century spent kind of going to war against microbes and figuring out how to kill them in every different way we can. And in a way, in the 21st century, you might have to kind of make peace with some of the microbes and learn how to live with them, or even better, how to help them, how to get them to help us treat disease. Sometimes poop is medicine. There's the takeaway. So I came back from traveling, having my eyes open in so many ways in India, ended up doing my residency in internal medicine and pediatrics at Mass General Hospital. You know, we call it Med-Peds, right? Why do only one residency when you can do two? One is for lazy people anyway, right? But I think actually, so medicine and pediatrics balanced each other really well. They complemented each other, and so things you learn from one were applicable kind of to the other aspect of medicine. You know, a lot of medicine residents would always be like, oh, I don't know how you treat children. You know, how do you take a history? They can't even answer your questions. They can't even talk. I mean, for a pediatrician, the answer to that's obvious. And then the pediatrician, peds residents would be like, oh, I don't know how you treat the adults. You know, they're so, they lie to you, and all they want is opioids, you know, not like perfect little innocent children. But actually, I enjoyed both. You know, both children and adults have redeeming qualities, it's true. And in fact, I thought that each was almost a way of getting out of the other bubble. So when you're in your internal medicine world, when you go to peds, it's almost like getting out of your bubble, getting better perspective on that bubble, as so often happens when we try new things or go to new places. So after I finished residency, let me just say I have not had a full-time job since I finished residency, not one. And it's given me a lot of flexibility in my schedule. I really like it that way, though sometimes having 3 part-time jobs can be a little bit of a juggling act to get your calendar straight each month. But I really like the opportunity to be able to travel and be able to kind of seek out these interesting experiences. So one of the first places I worked, so basically when I finished residency, I wanted to find places that had interesting cultural and interesting geographic contexts in which to practice medicine. So one of the first places I worked was in Kotzebue, Alaska, almost in the northwestern corner of the state, not quite. But it is about 55 miles north of the Arctic Circle. And just to give you a sense of how remote things are there, so the Northwest Arctic Borough, which is the borough that, so that red marker is on Kotzebue, the town. Kotzebue is the main town in the Northwest Arctic Borough. That borough is larger than Indiana, the entire state of Indiana. The state of Indiana has almost 7 million people in it, and this area, which is larger, has a total of 8,000 people. And 4,000 of them are in the one town of Kotzebue. So it's basically 4,000 people spread out over a state the size of Indiana. No roads, no medical specialists, no surgeons, only the doctors that worked in Kotzebue. There were midwives there also to help with pregnant patients. But you really get a different sense of when you're practicing medicine in a remote place like that, where there are no specialists to help you. And basically everything is about medical evacuation for anyone who needs it. And so everyone who needed anything from surgery to a cardiac cath to a colonoscopy to upper endoscopy, anything, they had to go to Anchorage, which you can see there down in the south central part of the state. Everything was by air. So even from the little villages spread out over the Northwest Arctic Borough to Kotzebue, everything would be by air. I mean, sometimes you could take a boat in summer or a snowmobile in winter, but really that would take some hours, sometimes days, to get from one village to the town. And so airplane flights were really everything. And so the decision whether to evacuate or not is something when you work in a large urban academic center, you don't really have to think about that. Because someone needs to go to cath, it's upstairs, and someone needs to go to endoscopy, it's the floor above that. So working in a place where there was nothing, none of those capabilities, you have to think about how to get that person to Anchorage. Do they need to go right now? Can they wait till later? Actually, when I worked at night, a lot of the times you're deciding, can this person, you know they have to go to Anchorage, do they have to go right now in an emergent medical evacuation, or can they wait till the morning, in which case they could just take a normal flight, like a normal commercial flight to Anchorage? And I definitely had several patients with like appendicitis who were stable and not in too much pain, who definitely waited till the morning and got on a normal flight, sometimes with an IV in. There was a whole system in place for that kind of thing, and a really great system, actually. And so you have to kind of take that into consideration. I was making decisions I never really had to make before working in a large hospital. Another thing you have to take into account is that when you evacuate from Kotzebue to Anchorage, the plane has to fly up and over the Alaska Range, which has Denali in it, the tallest mountain in North America, which is about 20,000 feet, just over 20,000 feet, the summit. And so that plane, when you go that high in the atmosphere, air tends to expand, including air inside the body. So patients have a pneumothorax, some air between the lung and the chest wall, or bowel obstruction, and perhaps their bowel are dilated and full of air. That air is going to expand when you go up above 20,000 feet, and so you need to take that into account. Sometimes we would put in a chest tube for very small pneumothoraces as a result, because they might grow when you're in the air. I had a trauma patient who had on a CAT scan, which we did have up there in the Alaskan Arctic. They had a little bit of air inside their skull after this head trauma called a pneumocephalus, and that was also going to expand, and we debated with the neurosurgeon for probably too long what we should do about it, and they ended up just going. But so those are other kind of geographic and even like topographical concerns that you have to take into account as a doctor. Also, working in the Arctic is just awesome. This is the town of Kotzebue on the left from a hill outside town. The Inupiat Eskimo always tend to live right on the precipice of the ocean, almost dangling out on the little peninsulas into the ocean, because that's how they made their living from fish and marine mammals. And on the right, some beautiful fireweed. There's nothing like the Arctic. And you get to see these sorts of interesting things. That's a mammoth tooth on the left. It was just on one of the doctor's desks in his office in the hospital. People dig them up sometimes in their garden, or they come up with a mammoth tusk every now and then, or on the coast where the water is kind of whittling away. And you see great place names like Ptarmigan Way. And even in the hospital, so you can see all the translations into the Inupiaq language, which is very hard to pronounce, and I did not learn much about, but it's really consonant heavy. And it's just interesting. These are the little details, the little interesting kind of idiosyncratic aspects of working in some of the small hospitals that are spread out across the country and across the world. This was a shot of Kotzebue. So I had a patient actually with an obstructing gallstone, and he had a very often deadly infection called ascending cholangitis, and he really needed either a gastroenterologist to do a scope to get that stone out of his bile duct, or a surgeon perhaps, and neither of those were in Kotzebue. So he needed to go to Anchorage. It just so happened there were a bunch of tundra fires burning outside of town, and the wind had shifted and was blowing all the smoke right into town, so no planes could come or go. So this patient was making me very nervous, and then started getting a fever and more tachycardic. And I was Googling how to put in a percutaneous cholecystostomy tube, because I had never done that before. I was actually watching YouTube videos, and thank goodness the smoke did not stop, but he passed the stone, it came out, and he got much better. And then a few days later went on a commercial flight down to Anchorage to get his gallbladder removed. All kinds of exciting things can happen when you're practicing medicine in the middle of nowhere. So after the Arctic, I went to Nepal. I worked for a group called the Himalayan Rescue Association. They staff what's called Everest ER, which is the medical care at Everest Base Camp. I feel like almost a third of the people there to climb Everest are also doctors, inadvertently, so you get a lot of medical care up there if you need it. Like when there was an earthquake and avalanche recently, I spoke to one of the healthcare workers that was up there, and it was like half the people were doctors also. There's like an orthopedist and a cardiologist, so everyone's like ready to help. So that's convenient. But so going to altitude is an amazing way to get out of your bubble, or at least the bubble of your physiologic understanding of the human body, because some very strange things tend to happen when you go up in the air. So things that we don't really understand very well. Altitude sickness can give you all kinds of different symptoms, can make your lungs fill with fluid, your brain swell. We don't really understand exactly the pathophysiology, why it happens, though we do have ways of treating it and preventing it. But talking about getting out of your bubble, so when I was there for 2 months in the town of Manang, working in the clinic along the Annapurna circuit, and my oxygen saturation was about 86, 87 for that entire time. Now, in the ERs where I work here at Cooper or elsewhere, like that's an emergency. We'll like move fast to fix that number, to get the oxygen level up, to give the patient supplemental oxygen, or to figure out why it's low and to treat that condition. But there it was normal. And so also at sea level, when I evaluate people in respiratory distress, one of the signs that we look for is, can they speak in full sentences without taking a breath in the middle of their sentence? And if they can't, if they have to take a breath in the middle of the sentence, that's a sign that they are in more significant respiratory distress, and we better move and figure it out and fix it soon. But up there in Manang, which is at about 12,000 feet, that was normal. I mean, I could not hardly finish a sentence without taking a breath, and it was totally winded, a normal conversation. Got out of breath, literally toweling off after a shower. even after I was there for several weeks. And that was normal, so I wasn't running to give myself oxygen. That was just how it was. And so here you can see some pictures of the clinic on the left. Quite impressively well-stocked clinic. All those boxes have medicine, and none of them were expired. This group, Himalayan Rescue Association, very militant about getting rid of all expired medicines, making sure everything is up to date, not expired, which is not always the case when you go to clinics in remote parts of the developing world. So that was actually quite impressive. On the right, you can see some tall mountains there. And keep in mind, this is at 28 degrees latitude north. This is the tropics, which just shows you how tall mountains have to be to get glaciers on them, right? When you're around Denali in Alaska, it's like 60 degrees latitude north. There, it's like you get a mountain, it's going to have a glacier on it. But here in the tropics, to really get that high, shows you how tall these mountains have to be. So after I came down from that high altitude trip, another place, I wanted to work on an Indian reservation in the lower 48, which is what the people in Alaska call the continental US. So I thought about going back to Alaska, but figured I would try somewhere else. So my sense of adventure and interest in culture and geography led me to the Pine Ridge Reservation in South Dakota. You can see it right there along the very southern border of South Dakota, right across the border from Nebraska. And this was eye-opening in many ways. So the county that Pine Ridge is in is called Oglala Lakota County, and it has the worst health statistics of any county in the US. Much better than in the Arctic Alaska, actually. The life expectancy for men and women is the lowest. Maternal mortality, neonatal mortality, many of those statistics are the lowest of any county in the US in this part of the world, or in this part of the country. Also, the levels of health literacy and levels of education were just very low. I often describe working on an Indian reservation as just like working in rural America, except more so. So every barrier to care, every whatever the issue is with health literacy or lack of transport, whatever barriers there are on the Indian reservation, there are even more. And I never saw so many patients as I did there who were in their 30s on dialysis from diabetes. You know, Native Americans have a higher risk than average of metabolic syndrome and its aspects like diabetes. And I lost count of how many people I saw whose kidneys had already been completely ruined by diabetes in their 30s. Also, alcoholism, huge problem, generally many rural parts of the world, but again, even more so on Indian reservations. And I saw more people in their 30s with cirrhosis, and really end-stage cirrhosis, than I really have. I'm not sure I've seen any that were that bad, as I saw pretty regularly there on the reservation. So that is a way of kind of opening your eyes too. And I think working in, the IHS, Indian Health Service, doesn't always deliver the highest quality health care, to be honest. And I think working in that setting where the resources are pretty minimal, there's no specialists, no surgeons, again, though at least you could drive to Rapid City, to a bigger hospital. You don't have to fly. But I think it teaches you to be more creative, teaches you to be more resourceful, teaches you to be a better problem solver, which is still useful even in a large urban hospital like Cooper or anywhere else. And another little interesting idiosyncratic quirk of working in this hospital, you see these sort of Native American themed decorations on the in the hallway and other parts, really amazing display cases with traditional crafts and things like that. You also, when you go out there, you get a taste of history and why things are the way they are, or at least part of the reason things are the way they are. And I was always fascinated with the history of the American government's wars with the Plains Indians. And a lot of people in Pine Ridge told me that they're sure that the reason the healthcare quality is so poor there is because the American government's getting back at them for things like Custer's Last Stand and all those wars that the American government lost a lot of soldiers to. And then in the 1970s with the American Indian movement, there was a shootout on Pine Ridge Reservation. 2 FBI agents were killed. And so people are convinced that those two things are the reason that their healthcare system is so dysfunctional. That it's revenge for all that stuff happening, which is sort of an interesting perspective anyway. All right, just a little bit more here. So one reason I like working in the ER is because you can work as ship doctor on cruises all over the world. So basically, the minute I got out of residency, I Googled Antarctica cruise doctor. and basically found a list of companies that run cruises down to Antarctica. Every northern summer, the cruise ships go to Alaska and Iceland and Svalbard and Franz Josef Land and Greenland. And then the southern summer, they go to Antarctica and the Falklands and other South Atlantic islands and South Pacific islands. And every one of those ships has a doctor on it. And they want ER doctors. So I was like, all right, I need to be an ER doctor. And so after a few years of working in all these different places, I did get on a trip. And on the left there, you could see the southern tip of South America. And so we sailed across the Drake Passage there, some of the roughest waters in the world, to the Antarctic Peninsula. I did not cross the Antarctic Circle, I'm so sorry to say. Maybe one day. And then on the right, I did one other trip where we went to the Russian Arctic. So that on the left, where that red marker is, that's Wrangel Island with a W. And so we sailed from the far northeast of Russia up kind of along that international date line you can see, up through the Bering Strait and then over to the island, which has tons of polar bears and whales and seals and walruses. That was, Kotzebue was remote, but working in some of these places makes it seem like it might as well be an urban academic center, because some of these places are much further afield, literally in the middle of nowhere, and the technology you have at hand is very minimal. I evaluated a patient in Antarctica. He was an elderly Japanese man. It was a Japanese tour with 160 passengers from Japan who came with their own translators, and he was confused and had a fever. And when I first assessed him, I felt his pulse with my hands, and I realized it was actually the first time I had felt a patient's pulse with my own hand, because I had gotten so used to just looking up at the monitor at the patient's bedside. And you can see not only the heart rate, but sort of the rhythm and some aspects of the electrical discharges of the heart. And so I realized, without the technology too, we practice in these high-tech bubbles with all these gadgets and gizmos that are constantly making noise. And when you get out there in the middle of nowhere, you actually have to use some of those very basic skills. So I currently live in Philadelphia, and I work in rural PA in a few different spots. That's the town of Pottsville, one of the places I work. It's not as exotic as the Alaskan Arctic, but it's certainly interesting culturally and interesting geographically for me, since I didn't grow up there, learned a lot about Pennsylvania Dutch cuisine, which I particularly like. And obviously, if you work here in Camden, you know that you don't need to go to the ends of the earth to get out of your bubble. There are people living in Camden or in surrounding towns that we often see here at the hospital at Cooper who live in a different world from many of us. And so getting out of your bubble here can be very valuable. And I actually remember when I was a med student here, I participated briefly in one of the projects by Dr. Jeffrey Brenner, where he was sending healthcare workers to people's houses who were coming to the ER a lot. And so I visited two different houses. One was a totally condemned, abandoned house that seemed to be falling down, and this man was living inside with multiple medical problems. And in another house, there was a woman who was too obese to stand up out of bed and couldn't access care in any kind of more efficient way than just calling the ambulance every time something was wrong. And so getting into people's houses really gets you out of your bubble sometimes. Working in the ER, we don't get to see it as much, but the paramedics who bring patients to us often do see the conditions in which some people live. Went too far there. But I think for this coming era, basically, it's going to be important for us to diagnose ourselves, to diagnose our own biases, to diagnose the things that the hospitals do wrong, like sleep in hospitals, right? There's a million studies that show sleep is important for recovering from a variety of medical conditions. Yet in our hospitals, we completely annihilate the ability to sleep. Not on purpose, but it's sort of a side effect of all these heart monitors, which are wonderful. It's lovely that the patient's heart rate and oxygen level are monitored without anyone standing next to them, but the result is a lot of false alarms and noisy alarms, and lights often are on, and noisy neighbors, and as a resident, you carelessly schedule medication administration for times that are totally inconvenient for the patient, but that maybe are convenient for the nurse. Too early in the morning, too late at night, or they're, vital sign checks in the middle of the night, waking patients up, even though most of them are probably very stable and don't need that set of vitals at 3 in the morning to disrupt their very important sleep. These are kind of other ways of getting out of your bubble. If you're ever a patient in a hospital, you'll quickly realize how terrible the environment is and how impossible it is to sleep. And in my book, I talk about a patient who I treated who had terminal cancer, and yet I was waking him up each morning and hating myself for it, because it was sort of like needs, I mean, not that there was any hope of him recovering, but just like let the poor, dying man sleep for a little bit longer. And that helped sort of change the way that I practice, and at least gave me more respect for people's sleep. Now I work in the ER, so we don't really let anyone sleep anymore. But as a hospitalist, that is very important. And we have to diagnose our hospitals. We also have to diagnose ourselves. Doctors are very susceptible to biases. We're kind of getting over our bias against drug-dependent people. We're finally seeing addiction as a disease. We're finally having treatments and promoting them that can help, as opposed to treating it like a moral failing or a crime. Maybe we're making progress in terms of seeing obesity that way too. I wrote about obesity in my book, and I've spoken with a lot of patients since who said that, it's not only that like the CAT scan has a weight limit, or the crutches are not big enough for them, or the wheelchair is not wide enough for them, but it's that every time they access healthcare, they feel judged, and they feel like doctors are blaming everything on their obesity. Now, some stuff might actually be related to their obesity, but not everything. And a lot of times there's a lot of shaming and shaming going on. And so I think that's something that we can work on too. But again, finding the right balance for yourself is as important, and one side of the coin from finding the right balance for how you treat your patients. And I think that you have to make the healthcare system work for you. You have to, shape the lifestyle that you want. And don't forget that doctors burn out a lot. And really, to be honest, commit suicide. I just heard 2 weeks ago, one of the residents I did residency with, she was an internal medicine resident at MGH and a cardiologist, and absolutely brilliant. She killed herself 2 weeks ago, and that was totally shocking, very upsetting. I mean, I haven't been in touch with her, but she's very successful at what she did. Obviously, that's not enough to, satisfy everybody. So you really need to look out for yourself. And by doing that, you are looking out for your patients. So it's not a matter of being selfish or anything like that. And a few parting thoughts. One is, I just want to emphasize the importance of getting a second opinion. Now, I say that to my patients, even when I'm the one giving them the first opinion. I often encourage them to get a second opinion. When my relatives call me and say, oh, the doctor said this and that, often my advice is get a second opinion. And it's not like a failing. It's not a weakness to have your patients get a second opinion. It's not that they don't trust you or don't have faith in you. It's not about any of that. Medicine's an art. It's not a science. It's not 1 + 1 = 2. And so, doctors are often wrong. I am often wrong. You will often be wrong. And it's important to recognize that. And really a commitment to medical education. The Berkowitz Family Fund does support medical education very strongly, and it's a wonderful thing. And I think we have to remember that the medical education mission extends to the public as well. We have to commit ruthlessly to educating the public on the evidence behind the treatments that we do, the dangers behind the things that we recommend against. And I think that just offering proclamations from on high is just not going to cut it. Nobody's listening to us anymore. We need to show them, we need to educate them, just as we're educating ourselves. And also, obviously, seeing things for yourself is crucial, as we said. So think of it like an autopsy. That's how we figured out how health and disease work, and that's how you can help figure out being a better doctor. I saw someone just the other day, someone who was seen, not at Cooper, but a different ER. They'd come in after a dog bite to the hand. They were prescribed Augmentin, the right thing to do. The Augmentin script got to the pharmacy. Wonderful, working great so far. And the patient came back 3 days later with a horrible infection on their hand. They hadn't gotten the antibiotic. There was a transport problem. Then they finally got to the pharmacy. The pharmacy was out of the medicine. They were waiting for a callback. They didn't get it yet. So that's kind of what you figure out when you try to see things for yourself. I tell my residents all the time, when you click enter on the order, it doesn't mean that the medicine's in the patient's vein. A lot has to happen for that order to become an administered medication. And the same is true, even more so, when we send people out into the world with prescriptions, with advice, with explanations, which honestly they probably completely forget 5 minutes after leaving the ER. And just please be humble. That's really important, be humble, right? Half of everything you're learning now is going to be wrong in 2 years. How can you not be humble about what you think you know? I just want to tell a brief story, very brief. I saw this recently. It's a video of the comedian George Burns talking to Johnny Carson years ago. So George Burns was 93 years old at the time, one of the oldest comedians still in show business, smoking a cigar, which was sort of his trademark. And Johnny Carson asked him, how many cigars do you smoke a day? And he said, about 15 to 20. As a 93-year-old man smoking 15 to 20 cigars a day. And Johnny Carson was very impressed and was like, wow, hasn't your doctor ever suggested cutting down? And George Burns says, my doctor's dead. Thank you very much.